So, without further ado, Ms. Talia Loeb, a PhD student from Johns Hopkins Bloomberg School of Public Health. Thank you.
All right. Hi, everyone. My name is Talia. I'm going to be presenting towards SHIELD 2.0, a rapid assessment of community readiness to improve the interface between law enforcement and behavioral health services in Appalachian, Kentucky. I wanted to start with a few disclosures. I have no financial conflicts of interest to report, and this study was funded by the National Institute on Drug Abuse and the National Institute on Allergy and Infectious Diseases. And I also wanted, because this is a qualitative study, to incorporate some of my positionality. So I'm originally from Baltimore, Maryland. I'm not from Kentucky. And as a PhD student, my focus has primarily been in academic research. So I do not have lived experiences in behavioral health, law enforcement, or as a person who uses drugs, though I was an EMT for several years. And I did contribute to the analysis and the writing of this work. And I wanted to give a brief content warning because there is going to be like a little bit discussion of stigma, and one of the quotes might be upsetting to some people. So we all know that incarceration is a structural determinant of health. It results in failure to receive adequate care, that there's increased risk of infectious disease, and there's an increased risk of overdose upon release. However, policing encounters themselves are also adversely impacting health outcomes among people who inject drugs. So these sorts of police encounters include arrests, being beaten by police, bribes demanded, fear of arrest, stopped and search, and syringe confiscation. And these are all associated with increased syringe sharing, reduced harm reduction services use, and rushed injections, and higher prevalence of non-fatal overdoses and HIV. So what we want to know is it possible to switch law enforcement from a barrier to a facilitator of harm reduction? And this is the motivating question behind SHIELD, which is the safety and health integration in the enforcement of laws on drugs model. I'm just going to call it SHIELD because that's long. So the mission is to protect those who serve, and it addresses primarily concerns of first responders regarding needle stick injuries, misinformation on infectious disease and needle stick injuries, and then fentanyl contact risks, naloxone, Good Samaritan laws, and most importantly, task shifting to the behavioral health workforce. And so this is done through basically a training approach. So it starts with a community partner development process to plan what the issues are, and then a train-the-trainer model where the SHIELD team trains the behavioral health workforce and law enforcement to engage in the training, and then the training is actually done. And this is done with a couple core modules, the first being occupational wellness, in which they identify and mitigate stress, burnout, and other mental health risks among law enforcement. Module 2 is occupational safety, so identifying and mitigating physical health risks like needle stick injuries and fentanyl exposure. And then the last module is public safety. So this is the part that talks about task shifting to the behavioral health sector to improve community safety. And this has been priorly implemented in Tijuana, Mexico, and in Missouri in the United States. So there have been a lot of studies to date in those prior implementations that show the effectiveness of SHIELD. So there was reduced hepatitis C incidence and HIV incidence. There was reduced needle stick injuries among first responders. There were increased intention to make referrals to harm reduction and actually increased referrals. There was improved occupational safety, improved interactions between behavioral health and improved interactions between law enforcement and people who use drugs. And then there were reduced arrests for syringe possession, and it is cost-effective compared to the standard of care. However, despite all of these effectiveness, it has some limitations. So there's limited sustainability and scalability in the current model, and there is a need for the behavioral health workforce. There are issues with the behavioral health workforce in interacting with with law enforcement that serves as a barrier for them implementing their services. And then there's significant stress, burnout, and turnover in behavioral health, and it's unknown if the SHIELD model can actually be translated to the behavioral health workforce for them to implement. And so that's the primary question behind this specific study, which is, can the behavioral health workforce be mobilized to implement SHIELD? And so SHIELD 2.0 is a translation as a tool for the behavioral health workforce. So the problem is that stress and burnout among the behavioral health workforce is prevalent, and part of this is because of the interactions with law enforcement. So they work often at cross purposes, meaning that their work often conflicts with each other, and we will talk about that a little bit later. So the approach here is to equip the behavioral health workforce to reduce friction and improve interface with public safety. And we hope that the ultimate goal is to improve these interactions and ultimately improve public health and public safety. And so this is done with an addition of a knowledge transfer step. So this is where the SHIELD team translates the SHIELD materials to the behavioral health workforce in order to implement it. And then the behavioral health workforce takes the rest of the model themselves. So they participate in the community planning process with law enforcement. They do the train the trainers with law enforcement trainers and themselves. And then the behavioral and law enforcement do the training. So this study we did in Appalachian, Kentucky, and this is an area that's been really hard hit by the overdose epidemic. It has 70% of the 220 counties identified by the CDC as high risk for an HIV and HCV outbreak. And justice involvement has increased in this setting. And this map just shows where Appalachian, Kentucky is with respect to the rest of the country. So moving on to methods. The goal of this study was to identify feasibility and acceptability facilitators and barriers for implementing SHIELD 2.0 in this context. We did this through in-depth interviews with 24 behavioral health workers, and this interview was done by a person that has extensive harm reduction service experience. And then we also did 15 law enforcement and ancillary criminal justice worker interviews, and this was done by a former prosecutor who is from Kentucky. And again, we did that for the reflexivity piece of we want to be able to get people's honest feedback and opinions. And so we did a thematic coding and deductive analysis of the results. So here you can see the overall results of our analysis, and we identified a few barriers and facilitators for acceptability and facilitators, and we'll go into some of these in more detail. So referring to acceptability barriers, the most important one, I think, is the cross purposes. So this is that the law enforcement and the behavioral health workforce are working at odds with each other. And we have one quote here from a behavioral health worker who actually has discussed their experiences with engaging people who use drugs in their services, and just when they're about to be ready for treatment, they have this negative interaction with law enforcement, and they say, F this, I am just gonna keep doing what I'm doing because they're just gonna arrest me anyway. And then there's also pretty prevalent stigma across the board, so stigma against people who use drugs, the behavioral health workforce, and against law enforcement themselves. So we have the common misconceptions among law enforcement against behavioral health, so people saying that replacing one drug for another is counterintuitive. There's also a pervasive stigma against people who use drugs by the law enforcement, with one of them saying that addicts are so manipulative. Oh my gosh, I mean, they do it for a living. And then behavioral health also expresses some prejudicial behavior against law enforcement, saying how desperate do you have to be to go to a state trooper to get help. However, there are some facilitators, which is good. There's interface acceptability, which is where they described that they were willing to work with the other party. So this is one law enforcement officer who said that they've been a big advocate that jails don't actually help the situation, and so he's gotten his team to be very pro-rehab. And then the second acceptability facilitator is that there are personal ties to the addiction overdose crisis. Like I said before, this is an area that's been really hard hit by the overdose epidemic in the United States, and so either themselves or family and friends have lived experience with addiction. And this one behavioral health worker, I think, encompasses it perfectly, where they said, there is not one person in this county that has not been affected by substance use, not one person. And so we think that this will facilitate the implementation of SHIELD because people will be motivated to try to do something about the ongoing epidemic. And then there is perceived need for more training for law enforcement. This was both by law enforcement themselves and by behavioral health workers, with one person saying that they're kind of in the dark right now, and the only option that they have is to arrest. So moving into feasibility, there's the intra-organizational barriers. And so this includes things like burnout and bureaucratic issues. So the law enforcement in this community, on average, only makes it 8 years in the field due to burnout. And this is the same thing with behavioral health workers, saying that people on the front line could probably make more money at Walmart, which is like a big box superstore for those that aren't familiar. And then the bureaucracy is limiting factor in most places anyway. So then we have socio-structural and environmental barriers. So in order for the behavioral health workforce to be able to do their jobs adequately, they need to be able to reach people who use drugs and be able to provide their services. And this is limited when people don't have jobs, limited transportation, housing issues. And if those resources aren't met, it's harder for people to focus on treating and working on their addiction or engaging in harm reduction services. And then in this region, there have been 2 major floods in the region that have resulted in displacement of people, which has made it difficult for behavioral health to do their jobs. And there have been some feasibility facilitators, including formal and informal efforts, a massive array of existing infrastructure of behavioral health services, and health department positioning to be able to implement this model. And so we're going to focus here a little bit more on the informal efforts, which we're classifying as outreach, mostly. So there was this one person who discussed that law enforcement officers had been brought into their service in order to see what they do and try to dispel some misconceptions. And they thought that it actually did help their perceptions. It wasn't what they thought it was. It was a different lens than what they thought, and it changed their perspective. And so we're hopeful that having improved interface between law enforcement and behavioral health through the SHIELD model will be feasible given this prior experience already. So going into some conclusions and next steps, we found that SHIELD 2.0 was perceived to be pretty acceptable and feasible. Although we did identify some barriers, these barriers underscore the reason for SHIELD 2.0 in the first place. So things like burnout, stigma, these are things that the model does address. This is a 2-phase study, so this was phase 1, and we're moving into phase 2 now, which is the tailoring and implementing of the intervention in 9 counties in this region. And behavioral health workers and the health department have reported being activated to deploy it. So sorry. We anticipate that the impact of this model will be increased referrals to treatment by law enforcement, increased utilization of harm reduction services, and decreased criminal legal system involvement, which we know would have significant impact for people's livelihood long term. And we will be running surveys to assess impact, where we will do surveys with people who use drugs through existing SNAP kiosk cohorts in the region. We will be doing further interviews with law enforcement, and we will be doing some implementation science-related work with the behavioral health workers. And so I'd like to thank all of the people that participated in this study, as well as the Harm Reduction Coalition of Eastern Kentucky and the Kentucky Health Department for working with us on this study, as well as the other study team members and authors. And a shout out to the PIs, Javier Cepeda, Leo Beletsky, and Eileen Pepetin, and for INSU for allowing me to present this work and for kindly giving me an award for a PhD student abstract. And that's just a testament to what this team was able to accomplish. And there's QR codes for the website and for both of them so that you can explore more if you would like to. Thank you.